Hello, my name is Giovanni Guaraldi, and on behalf of my co-authors with the coordination of the Bridge Foundation, I present this study that analyzed the gaps between clinical practice and guidelines recommendation in the management of older people living with HIV. Let us start from CROI. Mark Thompson gave us a very good narrative of his experience of a man aging with HIV and stressed some of the, let us say, biology issues referring to the biology of aging, like comorbidity, multimorbidity, the need for polypharmacy. But even more important, he told us the impact of aging on the effect of continuity of care and the need of support services for people living with HIV. He also quoted the issue about ageism, that is the stigma of being old. Imagine, for instance, no more being handsome, being very slow, and all this have an impact which increases the stigma of HIV and altogether have a negative outcome with regard of the health-related quality of life. What is the public health response to all these issues? And you know that WHO last year published a new global health strategies on HIV. And some of this somehow was incorporated whenever WHO says that we need to address the care of HIV, the care of older people with HIV within chronic care models. And of course, this means a lot. It means, first of all, the recognition that wellness is something that should be considered as a goal of treatment. Keeping this in mind, we asked to explore if the unmet need of older people referred to the compliance of HIV clinic to the national and international recommendation. In order to do so, we divided the study in two parts. In the first part, we studied guidelines and we tried to see which were the specific statements addressing older people care need. And in the second part, we asked to clinicians and to people living with HIV age more than 50 years, question in a survey that was run in the week including World AIDS Day, the 1st December 2021. The first part of the study was to compare guidelines. We compared international guidelines, EAS guidelines, and the Società Italiana Malattie Infettive guidelines and the CIMIT guidelines. Altogether, they are the reference guidelines. In Italy, you can see that CIMIT guidelines gets old, and so it's the last edition is 2017. Nevertheless, these two guidelines, to me, are very well done, are very clear to put some statement, very important. If you want to describe aging, you need to describe geriatric syndrome. First of all, you need to describe frailty, that much better than chronological age. It's related to adverse outcome. You are not able to measure frailty? Well, at least screen for frailty. Use some simple questions, simple tests. And this is it's a non-specialist skill that everybody can do it. You need to measure polypharmacy. You need to assess the risk of falls. But what is more important is that these two guidelines says that all this information needs a different way of care that is based on the principle of the comprehensive geriatric assessment. And even our most specific task, that is the management of antiretroviral therapy, should be run within this comprehensive geriatric assessment, because issues like comorbidities, issues like polypharmacy should be part of the decision on how to manage antiretroviral therapy. Altogether, let me say the guidelines are clear. The guidelines miss something, that is the final outcome. They quote health-related quality of life, but these guidelines do not tell us which tool to use, but more than that, how to incorporate the results into the care. And from a public health perspective, even the WHO document that I've just quoted do not even tell us which should be the target to be used at a public health condition. Let us move to the second part of the study. We interviewed 35 centers. I can't really say this is fully representative of the Italian population. Most of these centers are pre-selected because they may belong to the JEPO cohort, that is an Italian cohort of elderly people living with HIV. And it is said that 23% of this clinic had somehow a dedicated HIV service for older people, but I'm not really sure this is fully representative of the Italian population. And still, there's only 20% of this clinic that have access to geriatric consultation. But what is interesting is that when you move to people living with HIV, and we were able to interview 66 people aged more than 60 years, for 50 years, and most of them were living with HIV for more than 20 years. You see that there are some specific geriatric issues. For instance, loneliness, present more than 50% of the cases. The financial difficulties in facing healthcare costs, and the prevalence of frailty that was screened using the frail scale that tell us that there's 5% of this population that are frail. There's a 36% of them that should be referred for frailty assessment because they might be frail. And there's a very high burden of falls and polypharmacy in this relatively young population. And 42% have some kinds of functional impairment using the Duke activity status instrument. But what is even more relevant is that suboptimal health-related quality of life is present in more than 50% of population. And within these people, a big burden is represented by self-stigma. That is, people that perceive themselves negatively because of HIV status. And so let us summarize all this. And let me say, guidelines show the path, how to manage older people. Guidelines are clear. The geriatric principles are well depicted. The idea of assessing people using the comprehensive geriatric assessment and the measurement of geriatric syndrome is very well depicted. Nevertheless, this is not present in the majority of HIV centers. And so there's a gap. There's a gap because knowledge is there, but there's no resources to put in practice because a dedicated service, the possibility to collect this information is not in practice. It may be a cultural issue, it may be an organizational issue. And this is why there's so many unmet needs still present. Among all of them, I would like to focus the issue about health-related quality of life. We understand this is important, it is mentioned, but still we don't know how to collect, but even more how to use it in the context of the management. And so I hope that all this somehow call for action in order to improve the way in which older people can be measured and the way in which a health-related quality of life can be used in the context of the comprehensive geriatric assessment. I hope this may increase Italian HIV clinics to improve the care of older people living with HIV. Thank you so much for your attention.